Welcome to Hospice Explained. This podcast is intended as an educational aid and is only a resource to begin to understand the end-of-life season. It is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Please always seek advice from your physician or qualified members of your healthcare team with any questions regarding a medical condition.
Hello and welcome to Hospice Explained, episode number 98. I am your host, Marie Betcher RN. My goal is to decrease fear and increase education. In this episode, I am replaying my episode number 29, where I interview Chris Graham, PA. Chris is the co-founder of Stillwater Hospice that has locations in Montana, South Dakota, and Wyoming. I really like this episode. Chris explains the Medicare coverage for hospice patients. And if you go on their website, and I will have a link in the show notes, you can also see some short videos that also help explain it. I also want to mention that Hospice Explained has 3 affiliates. If you use one of the affiliate links, Hospice Explained will get a small commission. So please and thank you. My affiliates are with the Death Deck and the EOL Deck, helping you start conversations that matter. Casey Gaconio has a Death Doula School, which is a comprehensive program that will empower you to make a profound difference. And DNA is Love is offering Hospice Explained listeners a 5% discount. They have a menu of customized DNA-filled products for your loved ones and pets. Thanks for listening. On today's episode, I have a guest, Chris Graham, PA. He is the owner of 4 different rural hospice agencies in 3 different states in the Northwest. He has responsibilities in operations, finance, quality, compliance, as well as growth and development. Chris's background is clinical. He was trained and worked as a physician assistant in private practice and hospital-based medicine for 17 years. Chris also has experience sitting on network operating councils for hospitals, boards of directors for charitable organizations, youth sports coaching, and church leadership positions. He is married and a father of 3. Welcome, Chris. Thanks for being a guest on Hospice Explained.
Well, thanks, Marie. Appreciate you having me. I'm, like I said, I'm a big fan of your podcast. I think you have done great work, and I love the focus on end-of-life space and hospice space. I've been in hospice for 4 or 5 years now. Prior to that, had a lot of clinical experience, but have fallen in love with hospice and what it means to people who engage with us, patients, family, community, all of those things. As a practitioner, I thought hospice was so narrow, something I never really thought a whole lot about, and now being more involved, realized just how wide and deep that hospice is and how much of a difference it makes, especially in rural end-of-life care where I spend most of my time.
Chris, can you give us more information about rural hospice?
Stillwater Hospice that's our company. We started in 2017 in Billings, Montana. Billings is a town of about 110, 120,000 people. You know, it's in Montana, so it is rural. We've expanded into northern Wyoming, into Rapid City, South Dakota, and south of Rapid City into the reservation there, and then also into Bozeman, Montana, and the surrounding area around Bozeman. So we have definitely embraced and are immersed in rural end-of-life care. And I think it's a lot different than big city hospice is kind of how I think of it. Our nurses and our caregivers, our social workers, our chaplains drive a long way, see people. Sometimes all they do is drive all day long to see one person who might be 60, 70, 80 miles away. To me, it's important and it's so fulfilling because these people who live in rural America don't know about hospice. They've never had it maybe in their communities before. They don't think about it. I mean, none of us really think about it, as I've heard you say on some of your shows, that people don't think about it until it's time and it is the end of life. So many of our patients have never heard of it. They don't know that they've worked their entire life for this Medicare benefit that they've earned and they have and they get. They just don't know about it. really our mission has been to teach our communities, teach the potential patients, healthcare providers, senior centers, all of those people and communities about hospice and end-of-life care and what it actually means and not what it actually has been in some of these places.
Oh, that makes a lot of sense to me. Absolutely. My goal is to decrease fear and increase education regarding hospice. Chris, tell me the best you can about Medicare and patients that don't understand. How can we help them understand what's available?
Medicare treats hospice very much differently than the rest of medicine. Everyone knows, in regular traditional medicine, hey, if you go to your doctor, they bill Medicare or your commercial insurance a certain amount for that visit. And if they order lab work, they will bill for lab work. And if they prescribe physical therapy and the patient goes to physical therapy, the physical therapist will bill Medicare for that. And so it's all individual fee-for-service reimbursement or revenue from Medicare. Hospice is totally different. Medicare is who certifies at least Medicare certified hospices, and you can gain accreditation through Medicare from different sources. Different companies will accredit you. But basically what Medicare says is, here's a set of rules that you as hospice owners have to follow. You have to provide nursing care. You have to provide aides, home health aides. You have to provide chaplains, social workers, medical directors. You have to provide the pharmacy. You have to provide medical equipment, bereavement, grief support for a year after your loved one passes. These are all of the things that the hospice agency has to provide under their Medicare certification. And in return, Medicare says, we'll pay you a certain number of dollars per day for every patient you have on your service. That number changes based on where you are, what number of day the patient is on, and every year it changes. But basically, as a hospice owner, I know that if we have 10 patients on our service, we're going to get X number of dollars per patient per day. And then within those number of dollars per day, I have to provide this service that Medicare tells me I have to provide. So in some ways, it's very simple. Once a month, we bill Medicare. We say these were the patients on our service, and they send us a check for that amount. And then they will come out and survey us, and they'll do a chart review, and they'll do a review of our billing and make sure that we're doing all of the things that we say. But every single person who has Medicare and Medicaid in most cases has that benefit. It's 100% free to the patient and their family. There are not copays. There's not anything extra that people have to pay for through hospice. We're not allowed to do that. We provide these services, and in our case, we provide extra service, like we'll provide pet therapy, massage therapy, things like that Medicare says you don't have to provide, but we just do it above and beyond. But we can't charge the patient for those things. We just decide our community needs this, and we're going to provide it.
This is great information so families and patients know that Medicare covers the cost of hospice and they don't have to worry about debts and big bills coming after someone dies.
Yeah, so I think a lot of patients will call and say, well, how much is this going to cost? Or, we can't afford it. And a lot of people are very surprised to find out this costs nothing. And if you live in a skilled nursing facility or an assisted living facility, it costs nothing to the patient, to the family, to the facility. And so hospice can bring in extra help, extra resources for the facility, for the patient, for the family at no cost to anyone. And that's it.
That is a simple way to say it, that hospice is an addition to what's already being provided, whether it's at home or at a nursing home or assisted living. People do need to know that. Chris, you're a provider, you're a PA. How can we educate providers to tell patients about this benefit?
I think that's a great question, and that is one that we face every single day, especially in rural communities, but I think in all communities across the country, at least in my experience, providers are stuck on a couple of things. When I was a provider and worked in a hospital, I worked in neurosurgery and in trauma. And when we had patients, I never thought of hospice unless somebody was actively dying. That was the first and only time I thought about it, and I can't, it's just so wrong. The second thing that providers get stuck on is one of the criteria that Medicare has for someone who qualifies for hospice is a diagnosis that says the patient will pass away in the next 6 months if no treatment is instituted, and they die with normal progression of the illness, that they'll die within 6 months. That is not a hard and fast rule. But providers, they do have to say the patient is likely to die within the next 6 months. So sometimes they get stuck on that. The fact of the matter is that every patient who comes on hospice, if they come on Stillwater Hospice service, a Stillwater Hospice nurse sees that patient, make sure that they qualify. We have very specific guidelines to show if a patient qualifies. And if a physician writes admit to hospice and we go out and that patient doesn't qualify, then we don't admit the patient. So I think providers fall into this area, especially rural providers who forever, they've never had a hospice agency anywhere near them. And so they've said, okay, here's your, hydrocodone and your oxycodone. And oh gosh, now you're dying within the next week. We're going to admit you to the hospital. We're going to start an IV and we're going to make you comfortable. And that's not, as you know, and your listeners know, that's not what hospice is.
I 100% agree. That's a 180. Trying to get someone comfortable at home, then switching gears, admitting them to the hospital and giving them IV fluids for hydration. IV hydration is a subject I will bring up on a future podcast. Just the fact that they're going from home to the hospital where they may not even be able to have more than one person in attendance with them, that completely changes the dynamics and the goal of comfort care for the end of life at home. My goal with the podcast was to educate patients and families, but as I've started podcasting, the reality is providers need to know, when do I refer my patient on to hospice? Education is very important for patients, providers, and families, and that does help options.
We are trying to educate healthcare providers that it starts way before that. So our social workers and chaplains and nurses can meet the people, know the family, and help people transition from life to passing in kind of this beautiful and natural and happy way and make that experience great. Now, your question was, how do we do that? It's hard. We have organized a couple of statewide Zoom meetings, call in, and we do education that way. We do get on monthly medical meetings where we try to do like all staff meetings and we try to educate there. We try to do like grand rounds. We go to senior centers. We go to churches. We just try to educate like crazy so everyone really is on the same page, because I think it's just as important to educate the community as it is the providers.
I love it. That's perfect. Helping providers understand that most patients want to be at home where they can accomplish their goals for their end of life and meet the needs of themselves and their families. Because if they're not at home and they get admitted and maybe there's only one person that can be with them because of current policies regarding the pandemic and visitation.
I think that's a great point. And one of the things that we've really focused on with our providers is to try to get them to understand the complex grief pattern that people are going through. Maybe somebody is at home and they have this difficult dilemma. Maybe, do I put mom or dad in an assisted living facility or in a nursing home? They have that difficult decision. And now they've decided, okay, that is the best thing. And they're going to reside in this nursing home. And then the pandemic happens. And then maybe the staff or somebody brings COVID in and now the patient has this illness and now there's more guilt with the family member. And maybe they pass from COVID and there's even more complex grief and, oh gosh, did I do this? And I think providers aren't understanding that. And I always say one of the biggest reasons to order or to provide hospice to somebody is because that Medicare benefit gives the family a year of bereavement, a year of grief support that can be so complex that in many cases people aren't going out to look for that grief support if it's not offered to them. They're not just calling their physician or calling a psychologist or a counselor and saying, hey, I need grief support. But what we do is we reach out to those people. We know they're going to have grief or complex grief, and we really try to make sure that we're proactive in helping them. And so I think providers are starting to understand, gosh, there is more than just giving medications at the end of life. There is this huge overarching Medicare benefit that these people have earned. And if I'm not writing an order for hospice, I'm withholding their earned Medicare benefit. And that's what we're trying to get across to providers more and more.
What about somebody that has insurance? What about somebody who's not on Medicare? They're 64 and they haven't retired, they have medical. Why don't you speak to that?
Sure. And I can't speak for all hospice. Stillwater Hospice in Montana, Wyoming, and South Dakota, we take everybody. It doesn't matter. We are a for-profit hospice, Medicare certified hospice agency. We don't do anything else. We don't do home health. We just do hospice. So that's all I can speak to, but we take everybody. If you have a commercial payer and we don't contract with them, we'll try to figure out a way. And if we can't, then we'll never charge the patient a thing. Sometimes commercial payers, even who we do contract with, they'll have co-pays, or sometimes they have a partial pay or a co-insurance. We never collect those. We never collect anything from the patient. We cover that completely. If somebody is young and uninsured, we still take them as, we just call it charity care or self-pay or whatever, but we don't end up charging the patient in those cases. And I think this is common with most hospice agencies, but I don't want to speak for anyone else, but we take anyone and everyone. And again, most hospice agencies, I do think, go out and contract with commercial payers like United Health, Blue Cross Blue Shield, Aetna, those kind of things.
That makes sense. So people do need to know that hospice is available with medical insurance. What about when you said charity care? For most of those patients, don't they get some sort of medical benefit if they are without insurance and, unfortunately, end of life situation? Is there help for them for insurance, or do they just have to rely on charity?
Yeah, that's a complicated question. It depends on the state and it depends on the circumstance. If a patient is in the hospital and maybe, let's say, they get a sudden terminal diagnosis and they are young and uninsured, usually the hospital will help them apply for Medicaid. Again, depending on the state and if there's Medicaid expansion, maybe they qualify, maybe they don't. The hospital is motivated to do that so they can get any bills that they have paid for. So they'll often start that ball rolling. If not, and if we see a patient at home, we also have social workers who can start the ball rolling on that. And so there often is coverage. Sometimes there's not for whatever reason. Maybe it's the specific state that doesn't have Medicaid expansion, and maybe there's different circumstances. And so we never, at least our protocol is that we never wait for somebody to be admitted to hospice because of payer situations. We can try to figure that out later, but regardless, we bring somebody on and we tell them up front, if you want to set this up with self-pay where you're paying us this rate, then that's great. If not, then that's okay too. We won't charge you anything.
So, Chris, you're telling me that Stillwater Hospice does not discriminate based on age, based on ability to pay, whether they have any insurance or Medicare, Medicaid, etc. Is that correct?
Absolutely. We don't discriminate based on anything. Our criteria is that a patient qualifies for hospice under the Medicare guidelines. And that's it. As long as you meet those criteria and that you have a safe environment to be in. So the patient has to live in a safe environment where they do have a caregiver, because we don't have a facility. We just go to where the patient lives. And so as long as that's the case, then we see anyone and we see everyone. That it brings us to today where that has been very difficult, because we do believe in individual choice at the end of life, that patients should be able to decide when and how they pass, that families should be able to be around them. And that's been very difficult in this new age of the pandemic especially. And that's even translated into the employment front. We have a lot of employees, team members that may not want to get the vaccination, or that we have others who demand that everybody does. At Stillwater Hospice, our passion and the words we live by and the feelings that we live by are really that patients have the choice, that all of us have the choice. And one of those choices should be how we pass away, where we pass away, who is surrounding us when we pass away. And I think that brings so much power to the transition from life to passing. And whatever your belief system is, wherever you think you're going or not going, doesn't matter. If a patient and the family have control and some choice in that process, then I think it's powerful. I think it's better. And Marie, you and I have been with people many times when they pass, and sometimes it's not that case. Sometimes it's in a hospital room and it's not their choice. It's not how they would want to. And being in a situation like that versus a situation where somebody has been a part of their passing and has had some choice and there's been some intention to it, it's just night and day, that experience. It's so much more beautiful and so much more of a life process when they've had that choice. And so we try to give that to them. We try to give that to everyone. And I guess the only additional thing that I was saying is we believe in that choice so much that extends to our team members, our employees, our partners, everyone. We want everyone to be able to make their own lives exactly what they want. And that's the only place that's given us difficulty now is in this latest, the vaccine mandate and the things that, we have so many people who say, I want the vaccine. Someone says, I don't want it. I don't want anyone to have it, or I want everyone to have it. Trying to juggle that has just made hospice difficult. But what we try to do is, at the end of the day, we try to bring the patient what they want. We try to empower them, give them the choice to pass away under their terms.
I really appreciate hearing that. One of the things that you spoke about is choice and comfort and peace for the patient. But what we're not talking about, and both of us know, is the caregiver. The peace that the caregiver has, that they did every single thing their loved one wanted and or needed to die peacefully. I feel it does help the grieving process for those who know they did what their loved one wanted.
Absolutely. I couldn't agree more. I think that is a very difficult position to be in, to be the caregiver of a loved one who is passing. And when you've known that loved one for a long time, you have some idea of what they would have wanted or wouldn't have wanted. And we hear that all the time, right? Oh, mom would not have wanted this, or this is exactly what mom would have wanted. And so I think that empowering of people with choice absolutely extends to the caregiver. It may be in many circumstances more important than to the patient. The patient's going to pass, to be honest. In some ways, they have the easy way out. And the caregiver is left sometimes with grief, or grieving for a long period of time, or guilt. And I think it's our job in hospice to help empower them and to make sure that the patient's wishes and the caregiver's decisions are connected. And if we can do that, then we make it much easier, not only for the patient to pass, but then for the caregiver to live.
I agree. The caregiver will live knowing that they have done everything they could to help their loved one pass comfortably. And that does help, I believe, in the grieving process. Thank you, Chris, for joining me on Hospice Explained. I really appreciate all your wisdom and insight that you have brought to my listeners.
Thank you, Marie. I really appreciate it. I think that you do great work here. I hope that this type of work goes on. I hope you keep doing it. I can't wait to see and hear the next things you do in the end of life space. We love hospice. It's our passion. We're going to keep doing it every day, all day. It's what we do. And so I really just appreciate the opportunity to come on and talk a little bit of end of life with someone else who shares that passion.
Thank you, Chris, for sharing the passion you have for hospice with my listeners.
And thank you, listeners. I do want to let you know that I cut out a small section that talked about COVID protocols. That portion is still in its entirety on the original episode number 29. Thank you.
Thank you for joining me on Hospice Explained. Think about ways you can make a difference in someone's life. Also, please subscribe and share this podcast with anyone who would benefit from listening. Thank you.